in management of bone metastatic pain. Any questions from the audience?
Sir, my question is, like, in any case, if I interrupt the whole ladder and go for if I interrupt the whole ladder and go for any interventional procedures, or directly I go for an interventional procedure, do I still stand legally correct?
1001%. Because if you see the NCCN guidelines, they very clearly mention that you need not follow the WHO letter. For example, if a patient comes to me with something like 8, 9, 10 score out of 10, I'm not going to wait for him to give an NSA, go further. I'm sure either patient will refuse to come to me or he will go to somebody else. More than that, in going anybody else, my job is to give him pain relief. So that time I can definitely bypass straight to maybe intervention. Like for example, at least in Indian scenario, it is very true. A patient of a celiac something, I'm saying celiac cancer pancreas, comes to me with my 8, 9, 10 score and is from a remote village. Why am I going to wait for him to give my morphine and wait for ACT and all? I'll prefer to give, if everything is fine like coag and everything is INR, everything is fine. I'll prefer to give a celiac plexus block immediately so that his pain scores comes down from maybe 7 and 9 to 3. And thereafter rest of the things, because the biggest problem in Indian remote places is, forget morphine, sometimes even Combiform is not available there. So if I can bring down his pain requirement tremendously, I'm sure even if paracetamol over there, small pain here and there, can be taken care of. So you are 100% justified if you are bypassing the ladder. Definitely. It's been accepted worldwide. NCCN guidelines says that.
Thank you, sir. Any more questions?
There is a role of early intervention in all the cancer pain patients. So if pain is localized and you can think that only nerve block can help, then there's definite role. There are a lot of literature available now. So early intervention really makes a lot of difference. It improves the quality of life of the patient. And regarding breakthrough pain, I just want to say one more thing that, for example, a case of CA tongue patient is coming and his baseline pain is reduced with or stabilized with oral morphine. If you just give glossopharyngeal nerve block, patient will be able to eat, patient will be able to swallow, patient will be able to do all other activities. So breakthrough pain can be relieved with the combination of intervention, and we can reduce the doses also. So intervention pain as a whole, and there is no legal problem in giving intervention. And one more thing I want to say in bone mets pain also. Okay, yes. If patient is having severe bony metastasis pain, a trial of oral morphine should be given to the patient first, and then subsequently step by step we can try intervention, because in bone mets pain is very severe. Pain is mainly becomes worse when it is a breakthrough pain. For example, if patient is having bony metastasis in the vertebral column, her baseline pain is stabilized and patient is moving around, that time pain is there. So we should have a combination of the medication plus the this thing.
Since we have Brian, who is from MD Anderson, I would like you to weigh in on two things: your practice and the WHO ladder, and secondly, your experience with bony metastasis. I know you touched on some of those.
I just wanted to say his review of what we do at MD Anderson was spot on about all the different approaches to bone pain. You could have given my lecture tomorrow, because that's what I'll talk about in a little bit more detail. But we have to know that us here as pain physicians, we're not the only pain physicians treating cancer. Pain, it's the oncologists, the radiation oncologists, the surgical oncologists, all have a role in treating cancer pain. For example, single fraction external beam radiation, standard of care for painful bony metastatic disease, 1, 2, 3, 4 levels. What's new, and I'll talk about tomorrow, stereotactic radiosurgery. Is that better than external beam radiation for that bony metastasis? What I've heard also is that maybe in Sri Lanka, denacinab is available or coming to be available. Unfortunately, in the United States, they're not going to do the trial there. So that's very exciting as something for bone pain as well. That is not an intervention; it's an injection. Injection in the tummy goes across as a nerve growth factor inhibitor. So that's very exciting. That might be very good for India. Other things, with regards to bone pain and breakthrough pain, because there was 2 questions regarding that, is that bone pain is a combination of what I call, and my neurosurgeons call, biologic pain. The tumor in the bone, in the vertebral body, in the pedicle, and the tumor is causing release of this inflammatory soup in the nerves around that periosteum. That's pain all the time, lying, sitting, no activity, you're hurting. Radiation, single fraction, multiple fractions divided up, will help that. It may take a long time. So what's new, what's not evidence-based yet, which I'll talk about tomorrow, radiofrequency ablations, cryoablations might be useful for that because it's an intervention that can happen right away and help for pain. Other things that might be for breakthrough pain. You have that bony pain, periosteal inflammation, periosteal soup that hurts all the time, and then you have a fracture at the same time. So that's something called incidental pain, mechanical movement related pain, and so every time you cough, sneeze, move, transfer in bed, ouch, it hurts. Increasing your morphine for that is probably not a very good idea because it's pain that happens every now and then. You're just going to develop more of a opioid load. Breakthrough pain, ultra-fast acting preparations that we have in the United States might be what I use for that. Those patients, they need to get radiation as standard of care. If they can't lie completely still for that single fraction or multiple fractions of radiation, they can't do it, and they'll still hurt. So maybe that's the role for vertebroplasty, kyphoplasty for mechanical pain. Maybe that's the role if it's just biologic pain, but they can't lie still, for an ultra-fast acting breakthrough medicine. So that's why you use all this all together, all at once. Following, yes, I agree, WHO ladder, I 100% agree with that approach. But on top of that approach, I don't think, the difference is now, I don't think intervention is the last stage, it's all throughout. Because by the time they're seeing us, they get radiation, they get many, many different things, surgery, and starting with an NSAID may be inappropriate for that patient at that time. So any intervention to get them through, to keep them functioning, is very appropriate.
Thank you, sir. Now, we have already had a lot of lectures about neuropathic pain, so many discussions, so many sessions. Whenever neuropathic pain is associated with, cancer, I'd like Madam to tell what is your approach in those type of patients. Subramani, Madam.
Neuropathic pain, like we all know, it's nerve-related pain. Like in cancer, he mentioned that it could be due to chemotherapy, it could be due to radiation, it could be due to the pathology itself. In neuropathic pain, the difficulty is like control the pain. There is a slew of drugs, but you have to find the right one for that patient. And again, you can use n number of interventions, which include various sympathetic blocks. Like he said, if the patient has a huge pancreatic cancer, it depends on what situation, what time. When the patient's in pain, I would say a celiac plexus block would be indicated. So again, for neuropathic pain, good history, good exam, you have to take into consideration the socio-economic and the situation that the patient is in. And then decide, it has to be a combination that would control the neuropathic pain. The other thing that one should not forget is the psychosocial aspect when you are dealing with neuropathic pain. Sometimes the cancer itself is gone, but the patient is left with the neuropathic pain. So then you are dealing with chronic pain, in which case you might have to change your approach to that pain because you're trying to get that patient back to work. It's not that he's still getting cancer treatment, they cannot get back to their life. So those are all the factors that have to be considered.
Thank you, Madam. I think we can start with Sir about anticonvulsant, antidepressant. That should be our initial, and then we can move ahead to blocks.
I wanted to add some more thing over there. That is what we say in neuropathic cancer pain. Basically, I've got 2 dimensions. One can be acute cancer pain syndromes, or second are the what we call chronic cancer pain syndromes. Both are related with the neuropathic pain, or otherwise you will classify it as tumor related, where you can say that tumor is encroaching on the neurovascular bundle. Or second is treatment related, where all forms of treatment, like whether you have been surgery, chemotherapy or radiotherapy, where the nerves get entangled, they also lead to a neuropathic pain. Third, of course, what we say TTT. Third is totally unrelated, where you got already some neuropathic element and on top of that you got a cancer. So that's what we define. But the thing is, main crux of therapy here is intervention has got a very poor role over there. Mainly it is all these anticonvulsants. In fact, I can say opiates and all are also not very useful. But anticonvulsant, antidepressants and all other things, steroids, they play a major role over there. Unless it is necessary that you can do some intervention like intrathecal pumps and all those things. Otherwise, normally interventions doesn't carry much more weight.
Madam, would you like to answer?
Usually cancer pain is mixed type of pain. So almost our 50% patient will be having a neuropathic component associated. And particularly the patients who are undergoing cancer treatment, they are likely to have some or other neuropathic pain, like following chemotherapy, following radiotherapy, mucositis when patient is undergoing radiotherapy for head and neck cancer. And all this pain needs to be treated, and it is, we always add tricyclic antidepressant along with morphine, that is must, starting with 10 milligram at night, increasing 10 milligram, and if patient responds, increasing 10 milligram every week at the maximum dose about 60, 70, 150 milligram up to that. If he doesn't respond to tricyclic antidepressant, then anticonvulsant is added, like pregabalin or gabapentin. And usually patient responds, even both the drugs, tricyclic antidepressant plus anticonvulsant, patient usually responds and they do very well with this both other analysis medications.
Truly said, madam. Now, Dr. Rohita, I would like to ask you, what do you think, what is the role of interventions in cancer pain? As we have already talked, it's a fourth step, can be applied anywhere, wherever you feel like. What is your thought about it?
Very short, like, I think there are two things of doing, like, ongoing or continuous treatment, like, with pumps, or neuraxial analgesia, going with simple shelter, one go, like, treatment. For example, diuretic plugs, intercostal plugs, plexus plugs, those things, and phototomies, for invasive things. So I think those are the two main categories. So depending on the patient scenario,
as Guru sir already said, our Indian scenario is totally different. If a patient is coming from a very remote place and we think he won't have even time and money to come second time, we would definitely supplement with a neurolytic block or another block if required, and then we can definitely try medications on him. So definitely there is a role. It depends on where you are practicing, what is the criteria, what is the criteria of the patients who are coming to you. So it totally depends where you are working. Now I'd like to ask you people